This is for anybody, but possibly Ben or Paul. What do you think about the use of aborted human fetal tissue cell lines being used in the development and in the serums of any vaccine and for gene therapy injections? Easy topic.
Go ahead. He's a physician. I'm not a doctor.
Yeah, I mean, I think there's a host of issues with that. I mean, the key word, these are aborted fetuses that are now being utilized in a very utilitarian sense. And, the arguments for it are, well, they're already aborted, so why not use them for some good? The problem with that is it sort of encourages almost the commodification of an embryo, and for utilitarian purposes, and encourages abortion. Now the tricky part comes when we have certain medications or immunizations that come from a long line of tissues that originated a long time ago with aborted fetuses. And that's a little harder thing to deal with, because how far out do you have to be from a sin down the line before you're actually complicit with that? Becomes a tricky issue. But using aborted fetuses and developing medical goods from that enters this thing about how complicit you are in that original evil. One of the things I do, I'm a cardiac anesthesiologist, which means my specialty is for open heart surgery, and I do, I specialize in transplant surgery, heart and lungs, so this is kind of very relevant. I think I've done about 800 to 1,000 heart-lung transplants in adults and kids. And a lot of the technology that we used, especially in hypothermia, because we cool patients down, and the physiology of hypothermia, cold patients and their physiology, most of that science was developed during Nazi trials in prison camps on Jewish people, in testing, sticking Jewish prisoners in cold ice baths and watching physiologic responses to them. And they were testing for downed pilots in cold environments in the ocean. But we use a lot of that information in how we handle patients under deliberate hypothermic conditions in the operating room. Are we complicit in those atrocities that were done back in the 1940s? And so the same questions come up. How complicit are we when we use aborted fetuses? I mean, it's already done now when we develop technology. So I think if it's, when we're really close to it, when we're actually using aborted fetuses to develop certain technologies, yes, we are complicit in that evil. The question now comes, well, how far out do you have to be from that to still be complicit? I don't know.
Yeah, I mean, I just would add, I think I agree with Dr. Hoehner. I just would add that this problem of complicity is a really thorny issue, because I mean, look from the candy on the tables to who made the chairs to who makes our clothing. There are lots of injustices in the world in which we might be complicit. How do we know? How do we determine that? That's not to say that it's a good thing. It's to say that complicity is a really tough question. Some of you, if you're going into philosophy and ethics, pick up the question about complicity and do some work for us on that. There's been wonderful theological work done on it, but it's not doesn't answer all the thorny questions. So I would agree. We don't want to encourage the use of aborted fetuses. That just encourages abortions, and so we want to do everything we can to shut it down. But in the meantime, we have this legacy of beneficial therapies that have come from not just morally questionable, but morally illicit, as Dr. Roberts put it, morally illicit sources.
Okay. I want to get on to this next question because it's important. How are we to think about an individual who has committed suicide either by their own hand or physician-assisted suicide? And are they in hell? Before you all answer, I have to tell you that this issue has been a major concern for us at Anglicans for Life because when Canada started the medical aid in dying, one of the things we immediately realized was that we were going to have families who are also struggling with the fallout from the patient's decision. And I saw a correlation between the women who regret their abortion, and that's my situation, and the fact that we had to create healing programs to allow them to find forgiveness and peace. And so as Canada started to introduce medical aid in dying, we started working with two different folks who do grief counseling and are working to make sure that we have a great program for the family members after the facts, because that's the other side of it is not only are we dealing with the patients that made these decisions, but their poor families are now living with that grief, that regret, that questioning. So and I know this is this is another one of those big questions, but how are we to think about that individual who has committed suicide or has embraced medical aid?
Well, I'm waiting for Ben to give us the answer. But what I'll tell you is that in Washington we say, Senator, I have no comment on that at this time. My thoughts on this would be, I don't presume to know the eternal destiny of anybody. That is not within the sphere, I think, of medical ethics per se for any individual. We believe that Jesus Christ, and the book of Hebrews is pretty clear on this, once for all, offered up the sins for the entire world, including the sins that anybody could ever possibly commit. We believe that we affirm life. We do not affirm the taking of life. We do not judge. As I mentioned, we don't have an ethics gavel on what is this individual's eternal destiny. This is not mine to know. It is mine and ours to advocate the right and good, the life-affirming treatments, including ethical, licit treatments at the end of life to reduce the burden and provide the care and compassion. I think the point is for those of us who think and work in this space, physician-assisted suicide, there is another way. There's palliative care and hospice care, and done well. This is the right way. This is what we encourage, we advocate for, we preach towards. But there are, as you say, the victims. How does one care for the distraught, the guilt-ridden, someone who is burdened by a decision that they made or their loved one made? This is, to bring in Ben's comments, the mission of the church is to come alongside and not to judge, but to comfort and to reassure in Christ's goodness. Christ knows all the things that went into any individual's decision. Christ was there long before we got involved. I trust the Lord.
Thank you. Oh, go ahead.
Well, yeah, I think this is a real grave ministry question. And I just want to say three things about, suicide in general. And because I had a family member who committed suicide, actually two in our family. But, you know, the Lord knows the heart, and even if you consider it a grave sin, there is no sin greater than God's grace, period. But second, you know, the stigma with suicide originated in the Middle Ages, and it originated in a Roman Catholic situation where the reason we say, you know, they can't go to heaven was because they had no chance for penance or formal repentance in the sacerdotal system in Roman Catholicism, and that's where it got its stigma from that. The third point I want to make is we are all committing suicide every day. Okay, every time we sin, that's suicide, spiritual suicide, and so in a spiritual sense, we're all there because it's a willing commitment of an act that results in our eternal death. And if it wasn't for the grace of God in any of that, you know, we would be there. And so it's you know, like I said, God's grace goes above every sin. He sees the heart, and we have to, you know, we have to minister to those people in that way.
Yeah, I would just add, I think we all are aware, and we should continue to teach that the Bible nowhere condones suicide. There's a really potent illustration of Saul, you remember, who is leaning on his spear, which is a euphemism for committing suicide. And you need to read the rest of that story to see how David deals with the person who watched Saul do that. Not necessarily because he committed suicide, but there were lots of things going on there. But the Bible doesn't condone suicide. And that's why, that's another reason why we need, as both Dr. Hoehner and Dr. Roberts said, better options. In the same way we would say to women who are considering abortion and feel this is the only option that they have, to say, no, there are others. We'll come alongside you. We'll help provide for you and for your child. We'll house you. We'll feed you. You know, whatever's necessary, we'll do. We need to provide options for dying patients or those who are struggling with anxiety and chronic depression. And we have the tools to do that. Edmund Pellegrino, a mentor of all of us that Dr. Roberts mentioned this morning, Edmund Pellegrino says that once you remove the impediments that prevent you from thinking you only have the one option, and you tell patients and show them that you have effective pain management, he says most patients don't want euthanasia-assisted suicide. Look, our bodies crave homeostasis. We cling to life for good reason. So if we offer people a better option than ending their lives, and maybe spending time with their loved ones, and maybe reconciling with those that they need to reconcile with, if we offer them better options, maybe we could reduce the number of people who choose medical aid in dying. Yeah, there's an ancient litany of the church. I couldn't recite the Latin to you, but the paraphrase is, Lord, from a quick death, protect us. And I think that's so counterintuitive in our culture. We think that the best way to die would be to do something that we really enjoy with a little bit of chocolate in our mouth and just fall over and die, you know. But what about all of the reconciliation and preparation and family and friends and others that we want to circle us when we're dying? If we haven't, and for families, that unprepared for death is a painful reality, because we always live with the regret that there was something I wanted to say. I wanted to talk to them one more time. And so I think there are lots of good reasons why we need to provide alternatives to assisted suicide.
Ben, what you just said, I thought about what Dr. Allen said this morning at the opening, that when you're in a room when somebody's dying, it's sacred ground. And this question goes right along kind of with it, but strikes through it. When hospitals declare brain death of a patient, the family has very little time to find an attorney with specialized experience to fight the hospital. Very few attorneys have this experience. How can we find such attorneys, or what are some alternatives? I will also mention that some of these questions, Anglicans for Life is going to follow up on as well, because there are some ministries out there that are trying to do this kind of intervention, but they're few and far between.
So I think finding an attorney on short order who is knowledgeable in this space is going to be a very hard thing. Brain death, as it is declared now, even though I can disagree with the criteria as being valid because they are not comprehensive criteria. They are truncated. Enough of the brain is dead, not all functions of the entire brain. Regardless, it is the law. It is the current guidelines that have been accepted, are being accepted, and there's not a huge amount of appetite out there for doing, this brain death has kind of crept into us, into the social imaginary, as Charles Taylor would have put it. Everybody knows, hey, there's this thing called brain death. Not many people think critically about how the criteria came together and what's missing and why it is in some ways disingenuous. There's finding the lawyer, which may be hard, finding the lawyer who is knowledgeable in the space and case law and precedent. There's not much out there at this moment. There was a case of a young woman in Oakland, California, here about a dozen or more years ago, Yahe McMath, suffered cardiac arrest during a tonsillectomy, was pronounced brain dead. Her family said, she's not dead. She's warm. She looks like she's alive, and this is how many brain dead patients appear. Ultimately, they retained legal counsel. The patient was ultimately transferred to New Jersey, where they have a religious exemption. Many Orthodox Jews don't embrace the idea of brain death. And if you're going to find an attorney who will take this on, it's probably going to be among the Orthodox Jewish tradition and their support. I need to say one thing about brain death, and that is that whether the patient meets the legal criteria, whether they meet the additional criteria that I believe there is such a thing as brain death, and I believe there's additional criteria needed to diagnose it. This patient is mortally ill, devastating neurologic injury, overwhelming likelihood that he or she is not going to survive. And consequently, whether one diagnoses brain death or not, this is an end-of-life scenario, which requires compassion and expertise. And then you get into the idea of organ donation, et cetera. But in the absence of an organ donation situation, this is a devastating illness, devastating affliction. Much of the brain is gone. Some of it may not be gone. But it is time to talk about end-of-life care and how can we do right by this patient and their family with this neurologic injury, regardless of whether we bring the attorneys in.
Let me also say that there are steps that one can take before you are ready to hire an attorney in most hospital settings. In the last century, every hospital that receives Medicare and Medicaid funding has to have some mechanism in the hospital for addressing ethical issues that come up in patient care. Many hospitals have chosen an ethics committee as a way of doing that. And in our hospital, for instance, one of our hospitals, and the hospital I've served on an ethics committee for 10 years, anyone, whether they're a physician, patient, or patient family member, can request an ethics committee consult. And that is a step along the way to sorting out the issues, and then gives you some breathing space to then locate people who can represent your case if you think this is that way. There are also patient care representatives and others that you can call in. So there are mechanisms in place before you get to the place where an attorney is your only option.
Okay.
Yeah,
Oh, go ahead.
Oh, I mean, we could talk about this for hours.
Yeah.
It's go on forever. I just want to say something for my perspective, being on the receiving end of organ donation, in getting those organs. There's a mindset that goes on when a patient is declared brain dead and declared to be an organ donor, that once that decision is made, that those organs now belong to the recipient as soon as they find it. And we're sort of taught that. As soon as that patient's declared brain dead, they are sort of a life organ-preserving entity, that we are now doing everything we can to preserve that heart function as it now belongs to somebody else that we're going to put it in.
It's just a bank.
It's just
an
an organ bank. Now, and there's now technically there's something right about that, because yes, we have to now we're focusing on the recipient, and we have to keep those organs as good as we possibly can. But what it does is there's this immediate shift, like I'm sure Alan's seen this, now away from care of the patient or anything that is done specifically for that patient or their family. It's like it's taken away pretty fast. And interventions are sometimes started even before a patient is totally declared brain dead to start preserving the organ function for a future recipient. And for me, when we work on recipient teams, we want that from a technical point of view, but what is it doing to the donor and their family? I think some of the donor organizations come in so quick and are so aggressive and are pushing the boundaries of when can we take an organ, that this is up to you and your own conscience. I am fully for organ donation. I'm fully for transplant. I've done it, my life, career. But I have taken my check off my driver's license for automatic organ donation.
As have I.
Yeah. I want my family to decide, and I don't want it to be automatic. I want my family to decide and deal with it in consultation. I think we're getting to the point where to become an organ donor is the default, and you have to opt out rather than the other way around, where you have to actually opt in to being an automatic organ donor. And I think the current situation, I think we really have to rethink, individually how that works out. I don't want to be opted in automatically and take everything away from my family in that.
All right. Okay, well, let's go from brain dead to cardiac dead. Little humor there. Tough topics. If a person dies by the cardio method, the heart stops, are they still able to donate organs, or do the organs also die before transplant is possible?
So, how long have we got? So, a patient who is at the end of life, for example, and the nurse calls the physician who's on duty, we believe that Mr. So-and-so has passed. We go to the room, we examine the patient. And in the hospital room, the patient is at the end of life. They have died. There may be some tissues that are able to be procured, but for vital organs and kidneys and whatnot, those are not going to be procured from that patient. Now, in the ICU, when a patient is on life support, yes, as in, we mentioned this earlier, there is a time and a place for withdrawing life support and allowing natural death. In the organ procurement space, there is an opportunity to change the venue, and so that when one has life support removed, that is accomplished in the operating room, the patient is permitted to pass away by cardiac criteria, which is in most hospitals and jurisdictions. You take the endotracheal tube out, you stop the medicine supporting the blood pressure, and when the patient's heart has stopped for a period of 5 minutes, that patient is then legally dead by cardiac criteria. Once the physician pronounces the patient dead in the operating room, having withdrawn life support, then the organ procurement team can come in, procure the organs on short order, and so in the right setting, organs may be procured from someone who has died by that. Now, there's this new thing coming down the pike called normothermic reperfusion. Maybe that's for next year's conference.
Let's all say it together.
Normothermic, yeah, okay. And that is, gets into a cocktail of practices that are licit and good and organ preserving, and it also gets into some areas that crosses the line, that induces brain death as part of the life withdrawal process, or life-sustaining treatment withdrawal process. I thought about getting into that for my talk. We got into it probably too much already. It's very complicated, but the answer to this question is yes, we can withdraw life support in a setting where organs may be procured. Whether family can be present at the time of death in the operating room is institution-specific. We're just working through this policy at our own hospital.
Okay, I have a real quick question that I'm hoping you can answer, because there's another long question that I think is important as well. When a patient is in hospice and they're given morphine to make them comfortable, does the buildup of the morphine actually eventually take the patient's life?
Aha, the old double effect thing. So this is a philosophic construct that came out of I've got 5 minutes to answer the question. Okay, I'm sorry. So, the Catholics have been thinking about these things for centuries. Evangelicals, Anglicans, we're sort of late to the table, but could it be that the beneficial effects of morphine result in the possibly expected but unintended, very important, side effect of respiratory suppression? And does that indeed hasten death? Now, there's a fair amount of literature in the palliative care realm that suggests that the right use of medications, analgesics, sedatives, etc., actually may prolong life and improve quality of life as we approach the end of life. Now, that literature does not apply in the intensive care unit, and it may not apply in hospice. Now, in hospice, and I recently became my father-in-law's hospice doctor back in September, and the judicious use of morphine administered under the tongue, I think actually prolonged his life, and it made him more comfortable towards the end. And done rightly, and in the fear of God, morphine is Sir William Osler, father of modern medicine, referred to morphine as God's own medicine. Morphine and sedatives are good, and they provide relief of suffering at the end of life. Now, if one goes in with massive amounts of benzodiazepines like Valium or morphine, yes, you can intentionally hasten death. Perhaps this is what some people do in the hospice setting. It is not what is prescribed.
Okay. Has anyone ever been pronounced brain dead and their organs decided to be used for donation only for them to recover?
Not after the donation.
Not after the donation.
I want my liver back, okay?
Let me nuance that a little bit. In something Alan was talking about when I'm going to change the scenario. When a patient is brought to the operating room to have life support withdrawn, in the context of now being able to donate their organs. So they're not brain dead. They don't meet death criteria. They just want life support removed so that they will die. But let's just do it in the operating room so that immediately as death is pronounced, we can now take their organs, right? Vital organs like heart, liver, kidney, and all that stuff. And as Alan said, you remove the endotracheal tube, they stop breathing, you wait for the heart to stop for a certain amount of time. That time is it's arbitrary. And what I mean by arbitrary is the criteria is, well, how long do we have to wait for there isn't any spontaneous return of heart function, okay? But let's complicate that one more step. How long do we have to wait for there no spontaneous heart return with my intent of not helping it start? My intent is not to resuscitate it. So all of a sudden, intent comes into the picture, okay? Intent of the physician, intent of everybody becomes into a definition of death, okay? My early research was on brain resuscitation and how long does it take, and what can you do to reverse some of the effects of that. And it's a very gray area, and it's a lot longer sometimes than 5 minutes, depending on certain circumstances. So here you have a patient. Is he dead at 5 minutes? Well, it depends. Do I intend to do something about it or not? You see where it gets very, very gray. And I'm not really comfortable with intent being part of a criteria for death.
All right. Okay. The one question that came up twice was, is there legislation that should be considered federally to allow for brain death to be universally declared? And we are excusing the kids have to get off to their bus. So we thank you guys for being here, and safe travels and enjoy the march. And so let's kind of quickly just address, where are we on this legally, legislatively? Where should we be going?
So brain death was first proposed by Harvard professors in 1968. It wasn't until it was practiced, but it was not really set in stone or codified until 1981, President's Commission, Uniform Law Commission, et cetera. It wasn't until 1995 that the American Academy of Neurology came out with specific criteria. These were updated only in 2010, and they weren't updated again until 2013. Until 2023. Consequently, it moves at a glacial pace on updating criteria. There's in the past 10 or 12 years, there's been a lot of controversy from a lot of people over the brain death thing.
Wait till they're done talking, yeah.
And at some point, perhaps there will be enough agitation and advocacy. The scholars I've talked to, including Dan Sulmacy and others at Georgetown, I'll be interested to hear what Ben and Paul say, really believe that much of this is going to follow from the courts. It's going to be litigation and more litigation, and finally, perhaps this will get the attention of lawmakers. I don't expect any of that to happen during the current administration or in the current climate, because everybody loves organ transplantation. Everybody wants to be a donor. Nobody has read the fine print. But Ben, Paul, tell me, can we turn this around?
Well, there's a lot more at stake in definition of death than just the medical and organ donation. I mean, there's transfer of wills, there's transfer of estates, there's a lot of things that legally ride on a definition of death. And a specific point of death. And so, there are legal ramifications above and beyond, some of the medical things that we're talking about here that I think are, will drive these things eventually, But it is important to have a unified definition. I mean, you don't want to be dead in Louisiana but still alive in Texas, Yeah, I mean, you know, and we have a joke on our, you know, I've been on a number of hospital ethics committees, you know, and the joke is we have, you know, 9 ethicists and 1 lawyer who actually trumps everybody else. It all comes down to the legality of things.
Okay, Ben?
Can I just say this really quickly? We've talked about some really thorny issues last night and today. But I plead with you to not think of bioethics just as about dilemmas. Every time I get sick and I go to a doctor, we've entered a covenantal relationship in which I'm ill, I have a dis-ease that has made me uncomfortable or made me feel I need to consult a caring, well-prepared, ethical professional. And so I go to that is an ethical relationship. When you put me in a gown that has no back, my options are limited. So that's an ethical relationship. And don't think of bioethics just as dilemma. And secondly, and relatedly, I love these wonderful experts who write and who care for patients, but every church, nearly every church, has caring, well-prepared physicians or nurses who can help educate us about the medical aspects. And then we can bring, through our rectors and through our theologians and others, we can bring together a group that can work on these issues together in the context of the local congregation. And it's doable if we will take advantage of this prophetic opportunity we have to educate the churches about bioethics, and not just about dilemmas, but about good medicine.
Good place to stop that, and a good segue to a quick commercial that Anglicans for Life does have our end-of-life curriculum called Embrace the Journey, which goes into all of the topics that we have covered today. It's all about end of life, and it is a teaching tool. It's not fully comprehensive, but it does cover everything we've talked about, power of attorneys, things like that. So that might be a good next step for you to consider. Gentlemen, thank you. Thank you, thank you. You have shared such a gift with us, and it is yourselves, and we are just eternally grateful to you. Thank you for loving the Lord so much that you've dedicated your lives to protecting His word and life. So thank you all. Let's give Him a hand.